So our first presenter today is Dr. Abbas Bitar, who will be speaking on referrals for advanced heart failure therapies. Dr. Abbas Bitar is an associate professor in the Division of Cardiovascular Medicine. He received his undergraduate degree from American University of Beirut in Lebanon. He completed his residency training in internal medicine at Indiana University School of Medicine. He received his training in cardiovascular disease at the University of Louisville School of Medicine and completed his advanced heart failure and cardiac transplantation training at the University of Michigan, where he joined the faculty in 2017. Dr. Bitar is actively engaged in clinical practice and clinical research in the areas of heart failure, heart transplantation, and mechanical circulatory support. His research interest focuses on modeling outcomes of early postoperative complications for heart failure patients being evaluated for advanced heart failure therapies using a combination of risk stratification and by understanding the underlying pathophysiology. Dr. Bitar, you should be able to take over sharing your screen.
Okay. Thank you, Sarah.
Thank you.
Okay. Good morning. My name is Abbas Bitar. I'm one of the heart failure physicians. And today I'll be talking about how to identify patients who have features for advanced heart failure therapy or advanced heart failure, and when to refer those patients to be evaluated for advanced therapies. So heart failure, it is estimated that more than 6 million Americans have heart failure, and almost 3 to 3.5 million of those have heart failure with reduced ejection fraction. And the prognosis of patients with advanced heart failure is not great. So it is estimated that almost half of those patients will die within 5 years of diagnosis. And it is estimated that almost a quarter to a half of those patients have features or have advanced heart failure, and they will die within a year. Now, if you look into the ACC/AHA classifications or staging, those patients are classified into 4 stages, A through D. And when we talk about patients with heart failure with reduced ejection fraction, we're talking mainly about stage C and D. And when we talk about patients with advanced heart failure, we're talking mainly about patients with New York Heart Association class 3 or 4. However, this classification does not really stratify who needs to be evaluated for advanced therapy. And here comes the INTERMACS profile. And INTERMACS refers to the Interagency Registry for mechanically assisted circulatory support. So the INTERMACS stratified those patients to 7 profile from 1 to 7. And this here we're talking about stratifying patient with NYHA class 3 or 4. So 7 is a patient with an initial I3, and 1 is a patient with a full-blown cardiogenic shock who needs intervention within an hour. Now, for the most part, the patients who get evaluated by advanced therapies or end up getting either a VAD or evaluated for heart transplants falls between profile 1 and profile 4 for the majority of those patients. Now, what is the definition for advanced heart failure? I think the Heart Failure Association and European Society of Cardiology definition for advanced heart failure is one of the better definition. So this is a patient who has NYHA class 3 or 4, a patient who have either a left ventricle or right ventricular dysfunction or some kind of infiltrative disease or inoperable valvular disease, who presents with frequent signs or symptoms of pulmonary or systemic congestions requiring escalation of diuretics or frequent hospitalizations for fluid overload, or it could be a patient who has refractory angina or patients who requires initral for augmentation of his cardiac output. Also, they did incorporate some functional assessment by either a 6-minute walk test or by completing cardiopulmonary stress test. And I will go over those in detail in the coming 30 minutes. Now, the question that comes up, how prevalent is advanced heart failure? So if we look into the population in the United States, which is close to 300 million, it is estimated that close to 7 million have heart failure, and half of those have systolic heart failure, and close to 10% have class 3B and 5% have class 4. So that puts us at close to 250 to 300,000 patients who are candidate for advanced heart failure therapies. And as of now, the gold standard for treatment for advanced heart failure is heart transplant. However, if we look into the number of heart transplants over the last couple of decades, it hasn't changed in the United States. And here we can look into the blue bar. We can see that from the early 1990s till mid 20-teens, we've been doing somewhere between 3,000 to 3,500 heart transplants in the United States. That has to do pretty much to the donor pool, like how many donors are available. And that has not changed much over the last couple of decades. And over the last couple of decades, we have seen an increase in the number of left ventricular assist device implants. And part of that has to do with improved technology. So from the when we moved from the pulsatile pump to the continuous flow pump, initially to the axial and now to the centrifugal, the technology has improved significantly, and that resulted in improved survival and less complication. So here we can see kind of a significant growth in the pump being implanted. And the type of pump that have been implanted over the years has changed. So in the 2010s, we're implanting pretty much HeartMate 2. And then we started to implant more hardwares, and now we're implanting pretty much all the HeartMate 3, which is the only commercially available pump in the United States. Now, the question that comes up, what is the prognosis of patients with advanced heart failure therapy or ambulatory patient with advanced heart failure therapy? And this question was answered by the MedaMACS, which is the medical arm for mechanically assisted circulatory support. So in this study, they included 161 patients, and those patients had INTERMACS Profile 4 to 7. So those are patients with class 3B to 4. None of those patients are on inotropes, and none of those patients were listed for heart transplants. However, all those patients had at least one hospitalization for heart failure within the past year. And here we can see, with 1 year of follow-up, only 47.1% of patients were alive on medical therapy, 22% of those patients died, 15% ended up being transplanted, and then close to 15% had a VAD. And then when they stratified the patient based on their INTERMACS profile, we can see that INTERMACS 4, which is the sickest of this group of patients, at 1 year of follow-up, only 39% of the patients were alive without a VAD support. Now, as of all of you know, heart failure is a chronic progressive disease. And after each hospitalization or after each decompensation, those patient never goes back to their baseline. There is always loss of certain degree of cardiac reserve. And over time, many of those patients go into this cycle where they end up where they become refractory to medical therapy, either due to pump failure, intolerance to medical therapy, or shrinking function. And this is the importance of identifying this patient in this area and to refer them for advanced therapy evaluation. And the reason is, if they're identified late, more often than not, they end up with end organ dysfunction, which would preclude them from either heart transplant or VAD evaluation. Now, different clinical biomarker scores, imaging, and comorbid risk factors have been published as risk factors or as predictors for advanced heart failure therapy. I'm going to focus on some of those that would be most clinically significant or easy to identify in clinical practice. So by just reviewing a patient record, reviewing their heart failure hospitalization is a very strong predictor of worst outcome. And this data was taken from the CHARM trial. And what they were able to identify is that after each hospitalization, the risk of dying increased by threefold. So it increased by 300%. And here on the left graph, so they divided patients into two cohorts, those who had no heart failure hospitalizations, and those are patients with heart failure with reduced ejection fraction. And here we can see that the risk of mortality is the highest within the first month after discharge from the hospital, and it drops over time, but it never goes back to baseline or never drops to cohort of patients who haven't been hospitalized for heart failure. Another important piece of information is like how often those patients were hospitalized and how long they've been in the hospital. So if you look into this line, this is a profile for the patients who were hospitalized once for less than 7 days. So they're, out of dying because of heart failure in the first month is 4 times higher. And this would be the graph for a patient who had 3 heart failure hospitalizations for more than 3 weeks. And you can see they're out of dying because of heart failure in the first month is close to 15 times higher. So, heart failure hospitalization, duration of hospitalizations, and frequency are very strong predictor of outcome. Another clinical marker is weight. And usually we look at the BMI. So the lower the BMI, the worse the outcome. And this has been reproduced in multiple studies. And as we all know, heart failure is a catabolic state. And many of those patients, they just lose all their fat tissue, their muscle over time, and they become pre-cachectic. And it is believed that higher BMI might indicate a greater metabolic reserve or a increased tolerance to metabolic stress, and indirectly, some can feel less severe heart failure. So many of our patients, as their heart failure progresses, they do develop pump failure, and their blood pressure tends to run on the lower side. And one compensatory mechanism to maintain the blood pressure is for the body to activate the renin-angiotensin system. So their sympathetic system is pre-activated. And many of those patients become very intolerant to medical therapy for that reason. So, somebody whose blood pressure has been running in the high 80s, 90s, so the body response would be to upregulate the renin-angiotensin system and cause some vasoconstriction. And if we do a right heart cath on this patient, you will notice that their systemic vascular resistance has to be very high. And when those patients are challenged with an ACE inhibitor and angiotensin receptor blocker, usually their blood pressure drops significantly. So a patient intolerant to this medication, usually that's a sign that their heart failure is pretty advanced. And here in the study, this is exactly what they're able to identify. So patients admitted with heart failure who are able to tolerate an ACE inhibitor did way better than those who are unable to tolerate an ACE inhibitor. And this is a cohort of patients not on inotropes. And those who were not able to take an ACE inhibitor and required an inotrope, even the worse. Similarly, patient intolerant to beta blocker, and this is in the red line in here, this is from the INTERMACS registry, did way worse in terms of survival compared to those who were maintained on a beta blocker. It's the blue line, or those who were started on a beta blocker. And in the green line, this is the cohort of patients whose beta blocker were discontinued. And again, this is an indirect marker that those patients who are not started or their beta blocker was stopped, either because of cardiac output or worsening cardiac function or hypertension. Usually that's another sign that those patients' heart failure is way more advanced. Now, as heart failure progresses, there's less perfusion to the kidney. Again, there's activation of the renin-angiotensin system, there's more fluid retention, and over time we see more fluid retention, and we see more escalation of diuretic dose to keep those patients euvolemic or achieve euvolemia. And again, this is in an outpatient setting in a cohort of patients with ejection fraction less than 40%. As your diuretic dose increases over time, your survival drops. So again, higher dose of diuretic, and here this cohort, they used furosemide of more than 18 milligrams was a negative prognostic sign. Similarly, in the inpatient setting, as the dose of intravenous diuretic use increases, so does the mortality. Now moving to the physical examination part, usually when we see a patient in clinic, we try to put them into 1 out of 4 category, and that's based on whether they're perfusing adequately, and so we assess whether they're warm or cold, and we assess their congestion level, whether they're dry or wet. So ideally, we like all those patients to be warm and dry, and this category of patient will do better compared to the other 3 categories. And usually the worst cohort is going to be somebody who is wet and cold. And this is not well represented in this study, mainly because of small sample size. So this patient will do way worse compared to the other. And this is very important. So they're called, usually the cardiac output is inadequate, and that usually will lead to, end organ dysfunction. And the organ that we are most concerned about would be their kidney. And usually the heart and the kidney function affect each other. So any insult that affects the heart is going to affect the kidney, and any insult that affects the kidney is going to affect the heart. We talk about cardiorenal syndrome, and usually there is 5 types of cardiorenal syndrome. The type 1 would be an acute cardiac insult that's going to affect the kidney function. And the classic example would be somebody who had an ST elevation myocardial infarction. They have a drop in the cardiac output, and that will lead to a drop in blood perfusion to the kidneys. That could lead to acute kidney injury. Type 2 cardiorenal syndrome would be a chronic cardiac insult that leads over time to an insult to the kidney. Somebody with heart failure with reduced ejection fraction, and then their cardiac output slowly progresses over time for one reason or the other, and then that will lead to dropping kidney perfusion over time, lead to worse kidney function. And type 3 would be an acute kidney injury. Type 4 would be chronic kidney injury leading to a heart problem. And type 5 would be an insult that has to do nothing with the heart or the kidney, like sepsis, that will affect both organs pretty much. And kidney function is very important because we know that the lower the GFR, the worse the outcome. And this is in a cohort of patients admitted with acute decompensated heart failure. So we can see that the lower the GFR in admission, the worse the outcome. A similar pattern was seen in an outpatient setting, and this data was taken from the DISH trial, which included close to 7,000 patients with heart failure with reduced ejection fraction. So here we can see on the x-axis is your GFR, on the y-axis the survival. So the lower the GFR, the higher the mortality. We talk a lot about kidney. We talk a lot about kidney function because we know that chronic kidney disease, pre-VAD implant, even pre-transplant, entail a worse outcome post-VAD or post-transplant. And this data was taken from the INTERMACS registry. On the blue line, we can see this is a cohort of patients who had CKD stage 1 or 2. So they did better in terms of survival compared to those who had CKD stage 3. And we can see the cohort of patients with CKD stage 4 or 5. The green line did the worst. And a similar pattern has been reported in patients with heart transplant. Other biochemical marker we look at would be sodium level, and not uncommonly, when we see patients in clinic and we tell them that their sodium level is low, their first response is, well, maybe I should eat more salt. It's all the way around. So usually low sodium is a reflection of increased overall body fluid level. And as patients retain more fluid, their sodium levels tend to drop, and the lower the sodium, the worse the outcome. This is exactly what we see here. Another marker that gives us a sense about their overall nutritional status is the albumin level, and that has been replicated in multiple cohorts. So again, the low albumin is a reflection of a cardiac cachexia, and here we can see an albumin level of less than 3.4 was associated with worse outcome compared to those with a higher albumin level. A very common biomarker that we use on a day-to-day basis is natriuretic peptide, which is a hormone released from the cardiac myocyte in response to a stretch of this myocardial cell. And it does correlate with the filling pressures in most patients. So the higher the filling pressures, the higher the natriuretic peptide. And an important distinction is to not rely on a single reading of the natriuretic peptide. It's more the trend over time that has value. So in this cohort of patients admitted with acute heart failure, they measured their natriuretic peptide on admission and discharge, and they stratified based on the median level. So, and here we can see admission natriuretic peptide, whether the patient were above the median or below the median on admission, didn't predict outcome on follow-up. What matters is their natriuretic peptide after optimization. So this is someone who came into the hospital, their volume overloaded, they got diaries, they got optimized, and then on discharge, their natriuretic peptide was measured. So those whose natriuretic peptide dropped post-optimization did way better. We can see this in the upper curve, compared to those whose natriuretic peptide remained high despite optimization, that did way worse. And that could be a reflection of, persistently elevated filling pressures or a low cardiac output. And we know chronic congestion is a bad prognostic sign. Similar pattern was seen in the Paradigm trial. This is the Interactive trial. So they did measure natriuretic peptide level on those patients, and then they stratified those patients based on the cut value of 1,000. So those whose natriuretic peptide dropped to less than 1,000 did way better on follow-up compared to those natriuretic peptide who remained above 1,000. And this was irrespective of the treatment allocation arm. So a similar pattern was seen in the cohort of patients who received enalapril and Entresto. Now moving to the imaging part. So all our patients get an echocardiogram, and as you're all aware, the lower the ejection fraction, the worse the outcome. And this data was taken from the CHARM trial. Again, here we can see as your ejection fraction drops, the risk of sudden cardiac death increase and the risk of heart failure death increase significantly. And as the ejection fraction drops, there is some remodeling of the left ventricle. So the left ventricle gets larger and larger over time. And again, this implies a negative prognostic value. And here we can see as the left ventricle gets bigger, and this is from like first quartile through the fourth, the survival drops significantly. And that has a huge implication. So as the left ventricle dilates, many of those patients do develop a functional matter regurgitation. And the higher the grade of the functional matter regurgitation in this cohort of patients is the worse the outcome. And here the matter regurgitation is more of a marker of how big the left V is and the marker of the degree of LV remodeling. This is exactly what we see here. So the cohort of patients had only mild or no matter regurgitation, the better than the cohort of patients who had severe matter regurgitation. Another marker we'll look at is their pulmonary hypertension. So there is a direct correlation between mean pulmonary artery pressure and RV function. So the lower, the higher the mean pulmonary artery pressure, that will lead to a drop in right ventricular ejection fraction over time. Again, the most common reason for worsening RV function is bad LV function. And this is a study where they included 250 patients with cardiomyopathy, and all those patients had a cardiac MRI. And here we can see as your left ventricular ejection fraction drops over time, so does the RV ejection fraction. And in this cohort of patients, where they stratified the patient based on their RVEF, those who had an RVEF of less than 45% had a worse survival compared to those who had an RVEF of more than 45%. Now, moving to the functional assessment, two tests we perform in clinical are the 6-minute walk test and the cardiopulmonary stress test. So 6-minute walk test, it's, as the name implies, it just measures how far those patient walks during 6 minutes. Doesn't require much equipment, just need 100 feet hallway and just a patient to walk at the timer. And the test estimates a global and integrated response of all the system. And usually change of 50 meters is considered clinically significant in most disease states. So this data was taken from the ESCAPE trial. And here, again, we can see that the further the patient can walk, the better the outcome. So this graph, this is a cohort of patients who are sedentary. They can walk at all. So they did the worst compared to those who were able to walk close to 300 meters in 6 minutes. And this has been replicated in different diseases, such as heart failure, pulmonary hypertension, so on and so forth. Another functional assessment we do is the cardiopulmonary stress test. Two measurements we look at are the peak oxygen uptake and we look into the VE/VCO2 or ventilatory efficiency. And usually, so for the peak VO2, the higher, the better. For the VE/VCO2, the lower, the better. So the VEV CO2 is inversely proportional to the cardiac output. So the lower your VEV CO2, the higher your cardiac output is usually. So the peak VO2 have been used to stratify who would need to be evaluated for heart transplant. And this study was done in Colombia in the early 1990s. So they stratified patients to 3 cohorts. So group 1 is a group of patients who had a low peak VO2 and they were listed for transplant. Group 2 is a cohort of patients who had a peak VO2 of more than 14. And group 3 is a group of patients who had a low peak VO2 and they were not a candidate for transplant. So here, this is your group 2. This is the patient who had a peak VO2 of more than 14. So they did the best. And this is a cohort of patients. This is group 3. So they had a low peak VO2 and not a candidate for transplant. So they did the worst. On the graph on the right side of the slide here, you can see the people who had a peak VO2 of more than 14, so group 2, their outcome was pretty similar, close to those who were transplanted at 2 years of follow-up. Now looking into what happened to people with a high VEV CO2, again here on the x-axis is your VEV CO2, and here's your survival. So as the VEV CO2 increases or the higher the VEV CO2, the lower the survival. And when we combine both, the peak VO2 and the VEV CO2, they have a incremental value or prognostic value. So if both are normal, so the survival is the highest, both are low, survival is the lowest. And if one is abnormal, it will fall somewhere in the middle. Now the ACC and the HA came on with different mnemonics to help physicians identify who needs to be evaluated for advanced therapy. One of the mnemonic is I need help. So I stands for inotropes, and for HA class 3 or 4 or high natriuretic peptide level. E for end organ dysfunction, such as worsening renal function, liver dysfunction. E for low ejection fraction, multiple ICD shocks, frequent hospitalizations, signs or symptoms of fluid overload, pulmonary systemic congestion. L for low blood pressure, NP, prognostic medication like inability to tolerate medical therapy. What we did here at University of Michigan, we kind of came up with this graphic where we pretty much incorporate the same markers, but we try to allocate certain cut points to help physicians better identify when to refer a patient for advanced therapy. And we stratify those into 4 categories, like clinical, laboratory, imaging, and risk score data. So the clinical markers are pretty much what I discussed, like high diuretics, high HA class, frequent hospitalizations, low blood pressure, poor functional capacity on 6 minutes, or low peak VO2 or high VCO2, a laboratory marker like worsening renal function, high natriuretic peptide level, low albumin, low sodium, and transaminitis or signs or symptoms of hepatic congestion. Now the imaging, low EF, and moderate to severe MR and TR. Now, in the last few minutes, I'm going to briefly talk about the management of patients with advanced therapy. So when patient present with acute or cardiogenic shock or low cardiac output, usually the first step would be to try to support them. And we would use vasoactive medications, mainly inotropes. And the inotropes are used either as a bridge to temporary or durable mechanical support or transplants. In some instances, we use this medication temporary to reverse end organ damage, and we're able to wean those medication off. And in a small subset of patients that are not a candidate for advanced therapies, inotropes are used as a palliative treatment. Another concept that we do encounter in patients with advanced therapy is diuretic resistance, and this is multifactorial. It's thought to be due to reduced renal perfusion from low cardiac output. It's thought to be due to some kind of cardiorenal syndrome. Those patients with advanced heart failure over time with high diuretic dose, they get some distal tubule hypertrophy. So they tend to absorb more salt also in the loop of Henle. And not uncommonly, as those patient builds up more fluid, there's a lot of edema in the lining of the gut or their small bowels, and they don't absorb the oral diuretic as well. So they require higher dose of diuretics, and they require the use of a combination of a loop with a thiazide diuretic. In terms of temporary support to bridge those patients to advanced therapy, sometimes we use a balloon pump, Impella, Tandem, VA, ECMO. And what pump we use, what type of temporary pump we use, depend on what's coming out of the patients and how limited the cardiac output is. So each pump has its own advantages and disadvantages. And as I said, the ultimate treatment for advanced heart failure will be heart transplant. And there are strict criteria or strict indication and contraindication who would be and who would not be a candidate for that. And the other limiting factor is the number of organ available for transplantation. So usually those patients, they should be, they shouldn't have any absolute contraindication, which would be, history of non-compliance, active infection, diabetes mellitus with end organ dysfunction, no more than 3 A, chronic kidney disease for single organ transplant. And they should be very compliant to the medication, should have the social support to be taken care of after transplant. And as I showed this slide early in my presentation, again, the biggest limiting factor is the number of organ available for heart transplantation. And one thing I tell my patient that heart transplant is not a cure for heart failure, and mainly because the median survival for heart transplant in adult is somewhere close to 11 to 12 years. So at 11 of 12 years post-transplant, only 50% of the patients who get a heart are alive. And another alternative for patients who are not a candidate for heart transplant or have some reversible contraindication for transplant is to bridge those patients with left ventricular assist device. And here I have the pictures of the 3 pumps that you might see. And as I mentioned previously, the only pump we're planning right now is a HeartMate 3. The question is, how good are LVAD in terms of survival? So this is the rematch trial from 2001. So this is when they compared the HeartMate XVE, which is an old generation pump, versus optimal medical therapy in a cohort of patients who are not a candidate for heart transplant. So those are patients not a candidate for heart transplant. They have no option except medical therapy versus this new pump at that time. And here we can see the 1-year survival of medical therapy is close to 25%. And on the pump, it was close to 50%. Since then, the LVAD technology had came a long way. And this is the data from the INTERMACS from 2019. And here the 1-year survival was at 83%. Our center 1-year survival is above 95%. A big part of that has to do with 1, better technology, 2, better familiarity with pump management, and 3, better understanding and knowledge of the complications that can happen post-pump implant and how to mitigate or prevent those complications from happening. And here we're talking mainly about GI bleeding, infection, and stroke. Again, this is data taken from the INTERMACS. So the 1-year risk for infection is close to 25%, and the 1-year risk for GI bleeding is close to 25%, and the 1-year risk of stroke is close to 12 to 15%. So the risks are still high, and I think with better understanding of those pumps and better management, those numbers will come down over time. Now, when we ask patients how do they feel after they get their pump implanted, and this is assessed using the quality of Euroqual questionnaire or the Kansas City cardiomyopathy questionnaire. So pre-implant, they don't feel as well, and here's the score of 45. Post-implant, the score improves to the 71, and it remains pretty consistently elevated. So for the most part, the quality of life improves significantly post-implant. Now, in conclusion, heart failure is a progressive disease. Early identification of marker of advanced heart failure is key to refer those patients to an advanced heart failure center so that they are evaluated for either a VAD or heart transplant. And as of now, heart transplant remains the treatment of choice for suitable candidates. And a durable mechanical support is a valid alternative to transplant for patients with advanced heart failure. Thank you.